Welcome to Pediatric Case Review. Today's lecture covers Klinefelter Syndrome, providing a comprehensive clinical review. We will explore clinical presentation, diagnostic approaches, and evidence-based management strategies. This lecture is designed for healthcare professionals seeking intermediate-level medical knowledge about this important chromosomal condition. Case scenario: a 15-year-old male is brought by parents for delayed puberty evaluation. His height is 185 centimeters. Weight is 70 kilograms. Physical examination shows Tanner stage 2 for puberty development with small firm testes noted on examination. Question: when is Klinefelter syndrome most commonly diagnosed? Option A, prenatal period. Option B, infancy. Option C, adolescence. Option D, early childhood. The correct answer is C, adolescence. Klinefelter syndrome is most commonly diagnosed during adolescence when delayed or incomplete puberty becomes apparent. The classic presentation includes small, firm testes, tall stature, and delayed secondary sexual characteristics. In this case, the patient's advanced height combined with underdeveloped puberty and small testes should raise suspicion. However, many cases remain undiagnosed until adulthood when men present for infertility evaluation, making early recognition crucial. Case scenario: a 17-year-old male presents with concerns about breast development. Physical examination reveals bilateral breast tissue enlargement spanning 4 centimeters. Testicular volume measures 8 milliliters bilaterally. No galactorrhea is present on examination. Question: what is the prevalence of gynecomastia in Klinefelter syndrome? Option A, 10 to 20%. Option B, 30 to 40%. Option C, 50 to 70%. Option D, 80 to 90%. The correct answer is C, 50 to 70%. Gynecomastia affects approximately half to two-thirds of males with Klinefelter syndrome. This occurs due to testosterone deficiency combined with relatively increased estrogen levels, creating an imbalanced hormone ratio. The breast tissue development often causes significant psychological distress, particularly during adolescence. While testosterone replacement may help prevent progression, established gynecomastia may require surgical intervention for cosmetic concerns and improve quality of life. Case scenario: parents of a 12-year-old boy report academic struggles, particularly with reading and writing skills. Intelligence quotient testing shows a score of 90. The patient has received speech therapy since age 5. Social interactions appear somewhat awkward. Growth chart review shows height at the 90th percentile. Question: which cognitive feature is most common in Klinefelter syndrome? Option A, intellectual disability. Option B, language-based learning difficulties. Option C, mathematical reasoning deficits. Option D, memory impairment. The correct answer is B, language-based learning difficulties. Boys with Klinefelter syndrome commonly experience language and verbal processing challenges, including speech delays, reading difficulties, and problems with written expression. Intelligence quotient scores typically fall in the normal to low normal range, between 85 and 115. While not intellectually disabled, these individuals benefit significantly from early speech therapy, special education services, and targeted academic support. Early intervention substantially improves long-term educational and social outcomes. Case scenario: physical examination of an 18-year-old male shows testicular length measuring 2.5 centimeters and width measuring 1.5 centimeters bilaterally. Testicular consistency is firm throughout. No masses are palpated. Premasteric reflex is intact bilaterally. Question: what is the typical testicular volume in adult males with Klinefelter syndrome? Option A, 8 to 12 milliliters. Option B, 4 to 6 milliliters. Option C, less than 4 milliliters. Option D, 12 to 15 milliliters. The correct answer is C, less than 4 milliliters. Adult males with Klinefelter syndrome typically have testicular volumes under 4 milliliters, compared to normal volumes of 15 to 25 milliliters. This marked reduction results from seminiferous tubule hyalinization and progressive fibrosis. The testes feel abnormally firm on palpation. Small, firm testes represent the most consistent and reliable physical finding in Klinefelter syndrome, present in nearly all affected individuals after puberty. Case scenario: a 16-year-old male presents for clinical evaluation. Standing height measures 188 centimeters. Arm span measures 195 centimeters. Upper to lower body segment ratio is 0.85. Body mass index is 23. Question: what body proportion abnormality is characteristic of Klinefelter syndrome? Option A, short stature with normal proportions. Option B, eunuchoid proportions with increased lower segment. Option C, proportionate tall stature. Option D, increased upper segment length. The correct answer is B, eunuchoid proportions with increased lower segment. Males with Klinefelter syndrome develop characteristic body proportions due to testosterone deficiency affecting epiphyseal closure. This results in continued long bone growth, producing disproportionately long legs relative to trunk length. Arm span typically exceeds height by several centimeters. These eunuchoid proportions, combined with delayed puberty, often result in above-average height during adolescence, though adult height may normalize somewhat. Case scenario: physical examination of a 19-year-old male shows sparse facial hair, minimal axillary hair, and reduced pubic hair with a Tanner stage 3 distribution pattern. Voice quality remains high-pitched. There is no history of acne development. Muscle mass appears globally decreased. Question: which secondary sexual characteristic finding is least specific for Klinefelter syndrome? Option A, sparse body hair. Option B, decreased muscle mass. Option C, high-pitched voice. Option D, absence of acne. The correct answer is D, absence of acne. While males with Klinefelter syndrome often lack acne due to testosterone deficiency, acne absence is nonspecific and occurs in many individuals with normal hormone levels. In contrast, sparse body and facial hair, decreased muscle mass, and persistently high-pitched voice more specifically indicate androgen deficiency. These findings collectively reflect the hypogonadal state characteristic of Klinefelter syndrome and should prompt hormonal evaluation when present together. Case scenario: a 25-year-old male with known Klinefelter syndrome presents for follow-up. Body mass index is 32. Waist circumference measures 110 centimeters. Blood pressure is 140 over 90 millimeters of mercury. Physical examination reveals acanthosis nigricans on the posterior neck. Question: what metabolic complication has the highest prevalence in Klinefelter syndrome? Option A, type 1 diabetes. Option B, metabolic syndrome. Option C, hypothyroidism. Option D, hyperlipidemia alone. The correct answer is B, metabolic syndrome. Approximately 50% of adult males with Klinefelter syndrome develop metabolic syndrome, significantly higher than the general population. This increased risk results from testosterone deficiency promoting central adiposity and insulin resistance. The clinical presentation includes abdominal obesity, hypertension, dyslipidemia, and glucose intolerance. Comprehensive management requires lifestyle interventions including diet and exercise, combined with appropriate testosterone replacement therapy to address the underlying hormonal deficiency. Case scenario: a 30-year-old male with Klinefelter syndrome reports chronic lower back pain. Dual energy X-ray absorptiometry scan shows a T-score of -2.5 at the lumbar spine. There is no history of fractures. Serum calcium and vitamin D levels are within normal limits. Question: what is the prevalence of osteoporosis in untreated adult males with Klinefelter syndrome? Option A, 5 to 10%. Option B, 15 to 25%. Option C, 30 to 40%. Option D, over 50%. The correct answer is C, 30 to 40%. Untreated adult males with Klinefelter syndrome have significantly increased osteoporosis risk, affecting approximately 1/3 of patients. Testosterone deficiency during critical bone development periods leads to reduced peak bone mass and accelerated bone loss. The impact is most pronounced when hypogonadism persists through adolescence and early adulthood. Early diagnosis and testosterone replacement therapy can substantially improve bone mineral density and reduce fracture risk throughout life. Case scenario: karyotype analysis performed on an infertile male shows 47 total chromosomes. An additional sex chromosome is identified beyond a normal male complement. Peripheral blood sample was used for the chromosomal analysis. Question: what is the most common karyotype in Klinefelter syndrome? Option A, 48, XXYY. Option B, 47, XXY. Option C, 46, XY with S or Y deletion. Option D, 47, XYY. The correct answer is B, 47, XXY. This represents the classic Klinefelter syndrome karyotype, present in 80 to 90% of affected individuals. The extra X chromosome results from non-disjunction during parental meiosis. Variant forms include mosaicism, where some cells have normal 46, XY karyotype and higher aneuploidies with additional X chromosomes. Generally, phenotypic severity increases with the number of extra X chromosomes present. Case scenario: testicular biopsy from a 22-year-old male with Klinefelter syndrome shows hyalinization of seminiferous tubules, complete absence of germ cells, and Leydig cell hyperplasia. There is no evidence of malignancy on histopathologic examination. Question: at what age does progressive seminiferous tubule degeneration typically begin in Klinefelter syndrome? Option A, prenatal period. Option B, early childhood. Option C, puberty. Option D, adulthood. The correct answer is C, puberty. While males with Klinefelter syndrome are born with relatively normal testicular histology, progressive degeneration begins during puberty. Seminiferous tubules undergo fibrosis and hyalinization, with progressive loss of germ cells throughout adolescence. By early adulthood, most affected individuals have complete tubular hyalinization and absent spermatogenesis. This timeline explains why sperm retrieval for fertility preservation is most successful when performed during adolescence, before complete tubular degeneration occurs. Case scenario: laboratory evaluation of an 18-year-old male with delayed puberty shows testosterone of 150 nanograms per deciliter, luteinizing hormone of 25 international units per liter, follicle-stimulating hormone of 35 international units per liter, and estradiol of 30 picograms per milliliter. Question: what laboratory pattern is most consistent with Klinefelter syndrome? Option A, low testosterone, low gonadotropins. Option B, low testosterone, elevated gonadotropins. Option C, normal testosterone, normal gonadotropins. Option D, elevated testosterone, elevated gonadotropins. The correct answer is B, low testosterone with elevated gonadotropins. Klinefelter syndrome causes hypergonadotropic hypogonadism, classified as primary testicular failure. The failing testes produce insufficient testosterone, prompting the pituitary gland to increase luteinizing hormone and follicle-stimulating hormone secretion in an unsuccessful attempt to stimulate testicular function. Follicle-stimulating hormone typically rises more dramatically than luteinizing hormone. This hormonal pattern distinguishes primary testicular failure from hypothalamic or pituitary causes of hypogonadism. Case scenario: a 16-year-old male presents with clinical features suggestive of Klinefelter syndrome. Hormonal studies confirm hypergonadotropic hypogonadism consistent with primary testicular failure. Parents request definitive diagnostic confirmation before initiating any treatment. Question: what test definitively confirms the diagnosis of Klinefelter syndrome? Option A, testosterone level measurement. Option B, testicular ultrasound. Option C, karyotype analysis. Option D, semen analysis. The correct answer is C, karyotype analysis. Chromosomal analysis represents the definitive diagnostic test for Klinefelter syndrome, typically performed on peripheral blood lymphocytes. Karyotyping identifies the classic 47XXY pattern and detects variant forms including mosaicism and higher aneuploidies. While hormonal studies and clinical features may strongly suggest the diagnosis, only chromosomal analysis provides definitive confirmation. Karyotype should ideally be obtained before initiating testosterone replacement therapy to establish the diagnosis with certainty. Case scenario: a 28-year-old male with Klinefelter syndrome desires biological children. Semen analysis demonstrates azoospermia. His testosterone level is 300 nanograms per deciliter while on replacement therapy. Follicle-stimulating hormone is 40 international units per liter. Question: what procedure offers the best chance for sperm retrieval in Klinefelter syndrome? Option A, standard testicular biopsy. Option B, microsurgical testicular sperm extraction. Option C, percutaneous epididymal sperm aspiration. Option D, repeated semen analysis. The correct answer is B, microsurgical testicular sperm extraction. This procedure offers the best success rate for sperm retrieval in Klinefelter syndrome, with approximately 50% of patients having viable sperm recovered. The technique involves careful microscopic examination of multiple testicular areas to locate rare focal areas of spermatogenesis. Success rates are higher in adolescents and young adults before complete testicular degeneration occurs. Retrieved sperm can be used immediately or cryopreserved for future intracytoplasmic sperm injection procedures. Case scenario: a 14-year-old male is diagnosed with Klinefelter syndrome. Physical examination shows Tanner stage 1 pubertal development. Testosterone level is 50 nanograms per deciliter. Luteinizing hormone is 18 international units per liter. Bone age radiograph shows 13 years. Current height is 175 centimeters. Question: at what Tanner stage should testosterone replacement therapy typically be initiated? Option A, Tanner stage 1. Option B, Tanner stage 2. Option C, Tanner stage 3. Option D, after completion of growth. The correct answer is B, Tanner stage 2. Testosterone replacement should typically be initiated when puberty would normally begin, around Tanner stage 2 or age 14 years. Starting treatment at this developmental stage ensures age-appropriate pubertal progression while optimizing bone health and psychological well-being. Therapy begins with low doses, gradually increasing to adult replacement levels over 2 to 3 years, mimicking normal pubertal testosterone increases. This approach balances promoting development with allowing reasonable height attainment. Case scenario: a 20-year-old male with Klinefelter syndrome is currently receiving testosterone cypionate at 200 milligrams intramuscularly every 2 weeks. He reports significant mood fluctuations, with energy peaks immediately after injection followed by fatigue before the next dose. He prefers an alternative treatment providing more stable hormone levels. Question: which testosterone formulation provides the most stable serum levels? Option A: intramuscular testosterone enanthate every 2 weeks. Option B: transdermal testosterone gel daily. Option C: oral testosterone undecanoate. Option D: subcutaneous testosterone pellets. The correct answer is B: transdermal testosterone gel daily. Daily gel application provides the most stable serum testosterone levels, avoiding the significant fluctuations seen with intramuscular injections. Typical dosing ranges from 50 to 100 milligrams applied daily to clean, dry skin. While subcutaneous pellets also provide stable levels, gel offers easier dose adjustment. Patients must apply gel consistently and take precautions to prevent transfer to others through skin contact, particularly children and pregnant women. Case scenario: a 25-year-old male has been on testosterone replacement therapy for 2 years. Baseline hematocrit was 42%. Current laboratory results show hematocrit of 54%. He reports no symptoms of hyperviscosity. Blood pressure is 120 over 80 millimeters of mercury. Question: what is the recommended action for hematocrit above 54% on testosterone therapy? Option A: continue current dose, recheck in 6 months. Option B: reduce testosterone dose or discontinue temporarily. Option C: start aspirin therapy. Option D: increase testosterone dose. The correct answer is B: reduce testosterone dose or discontinue temporarily. When hematocrit exceeds 54%, testosterone dose reduction or temporary cessation is recommended to reduce thrombotic risk. Testosterone stimulates erythropoiesis, and excessive elevation increases blood viscosity and venous thromboembolism risk. After hematocrit normalizes, testosterone can be restarted at a reduced dose. Some patients may require periodic therapeutic phlebotomy if polycythemia persists despite dose optimization. Regular hematocrit monitoring every 3 to 6 months is essential. Case scenario: a 35-year-old male with Klinefelter syndrome presents with a painless unilateral breast mass. The mass is firm, measures 3 centimeters, and appears fixed to underlying tissue. There is no nipple discharge. No lymphadenopathy is palpated. Family history is negative for breast cancer. Question: males with Klinefelter syndrome have increased risk of which malignancy? Option A: prostate cancer. Option B: testicular germ cell tumors. Option C: breast cancer. Option D: lung cancer. The correct answer is C: breast cancer. Males with Klinefelter syndrome have 20 to 50-fold increased breast cancer risk compared to the general male population. This dramatic increase relates to gynecomastia, testosterone deficiency, and relatively increased estrogen exposure. While still rare in absolute terms, breast cancer represents the most significantly elevated malignancy risk. Any breast mass in a male with Klinefelter syndrome requires prompt imaging and biopsy. Regular clinical breast examination should be part of routine care. Case scenario: a 40-year-old male with Klinefelter syndrome has been non-compliant with testosterone replacement therapy for the past 5 years. Body mass index is 35. Lipid panel shows total cholesterol of 250 milligrams per deciliter, low-density lipoprotein of 170 milligrams per deciliter, and triglycerides of 200 milligrams per deciliter. Question: compared to the general population, cardiovascular mortality in Klinefelter syndrome is Option A: decreased by 30%. Option B: similar to general population. Option C: increased by 30 to 50%. Option D: increased by 100%. The correct answer is C: increased by 30 to 50%. Males with Klinefelter syndrome face significantly elevated cardiovascular mortality due to multiple risk factors including metabolic syndrome, obesity, type 2 diabetes, and chronic hypogonadism. Untreated testosterone deficiency worsens these cardiovascular risks. Comprehensive management requires testosterone replacement, aggressive lifestyle modification, and treatment of metabolic complications. Regular screening for diabetes, dyslipidemia, and hypertension, combined with appropriate interventions, can substantially reduce cardiovascular mortality in this population. Case scenario: a 17-year-old male with Klinefelter syndrome reports persistent sad mood, social withdrawal, and academic decline over the past 6 months. Sleep disturbance is present. He denies suicidal ideation. Previously outgoing and social, he now actively avoids interaction with peers. Parents express concern about possible depression. Question: what psychiatric condition has the highest prevalence in Klinefelter syndrome? Option A, bipolar disorder. Option B, schizophrenia. Option C, anxiety and depression. Option D, obsessive-compulsive disorder. The correct answer is C, anxiety and depression. Males with Klinefelter syndrome experience 2 to 3-fold increased rates of anxiety and depression compared to the general population. Multiple factors contribute, including physical differences like gynecomastia, learning difficulties, social challenges, and potential hormonal effects of hypogonadism. Comprehensive care requires screening for mood disorders, psychological support services, and appropriate psychiatric treatment when indicated. Optimizing testosterone replacement may improve mood, though dedicated mental health treatment is often necessary. Case scenario: a 26-year-old male diagnosed with classic 47XXY Klinefelter syndrome successfully undergoes testicular sperm extraction with viable sperm retrieved. He is planning intracytoplasmic sperm injection with his partner. He requests detailed information about chromosomal risks for potential offspring. Question: what is the risk of chromosomal abnormalities in offspring conceived through intracytoplasmic sperm injection using sperm from males with Klinefelter syndrome? Option A, no increased risk. Option B, less than 5%. Option C, 10 to 15%. Option D, over 30%. The correct answer is B, less than 5%. Research demonstrates that viable sperm retrieved from males with Klinefelter syndrome generally have normal chromosomal constitution. The aneuploidy rate in offspring conceived through intracytoplasmic sperm injection is slightly elevated but remains under 5%. Despite this relatively reassuring data, pre-implantation genetic testing is often offered to detect chromosomal abnormalities before embryo transfer. Comprehensive genetic counseling should be provided to all couples before attempting conception using retrieved sperm. Case scenario: karyotype analysis demonstrates a mixture of 2 cell lines, 80% showing 47XXY pattern and 20% showing normal 46XY pattern. The patient is 18 years old. Testosterone level is 400 nanograms per deciliter. Testicular volume measures 12 milliliters bilaterally. Question: how does mosaic Klinefelter syndrome, with both 46XY and 47XXY cell lines, typically differ from classic 47XXY? Option A, more severe phenotype. Option B, milder phenotype with better fertility potential. Option C, no clinical differences. Option D, always requires earlier treatment. The correct answer is B, milder phenotype with better fertility potential. Mosaic Klinefelter syndrome typically presents with less severe features than classic 47XXY. The presence of a normal 46XY cell line provides some preserved testicular function. Clinical severity depends on the percentage and tissue distribution of normal cells. Some mosaic individuals maintain limited spermatogenesis, presenting with oligospermia rather than complete azoospermia. These men may have better spontaneous fertility potential or higher sperm retrieval success rates. Case scenario: a 28-year-old male with Klinefelter syndrome presents complaining of fatigue and cold intolerance. Laboratory studies reveal thyroid-stimulating hormone of 12 microinternational units per milliliter and free thyroxine of 0.6 nanograms per deciliter. Antithyroid peroxidase antibodies test positive at high titer. Question: which autoimmune condition shows increased association with Klinefelter syndrome? Option A, type 1 diabetes mellitus. Option B, autoimmune thyroiditis. Option C, rheumatoid arthritis. Option D, celiac disease. The correct answer is B, autoimmune thyroiditis. Males with Klinefelter syndrome have 2 to 3-fold increased risk of developing autoimmune thyroid disease, particularly Hashimoto thyroiditis. The mechanism may involve X chromosome gene dosage effects influencing immune system regulation. Other autoimmune conditions, including type 1 diabetes and systemic lupus erythematosus, also show modest increased prevalence. Regular screening with thyroid-stimulating hormone testing is recommended, with treatment initiated when hypothyroidism develops. Autoimmune screening should be considered when compatible symptoms arise. Thank you for watching this comprehensive lecture on Klinefelter syndrome from Pediatric Case Review. We have covered clinical presentation, pathophysiology, diagnostic approaches, treatment strategies, and important complications. Early diagnosis through recognition of characteristic features enables timely testosterone replacement and comprehensive management addressing hormonal, metabolic, psychological, and fertility concerns. Multidisciplinary care optimizes long-term outcomes. Please follow Pediatric Case Review channel for more informative medical presentations. If you have questions or interesting cases to discuss, please share them in the comments below. Thank you for your attention.